Okay, so this is a lecture where you will learn what exactly goes in the S, O, A, and P portions of the SOAP note. Before we get into that, we're going to have a brief review of why we do SOAP notes and also guidelines for documentation. So we utilize SOAP notes because they communicate how the patient is progressing. They help assess problems that may develop during the treatment session. They help develop timeframes for progression within the plan of care. And this helps make discharge recommendations and recommend other healthcare treatments. And on that make discharge recommendations as a PTA, that is some wording that you'll have to be careful with, and we'll go into that a little bit more in a later slide. So here are your guidelines for documentation that we've gone over, but we're going to briefly review them again. Our documentation needs to be timely, thorough, relevant, accurate, and logical, clear and concise. And I've told you guys before, you're not going to be very concise to begin with. That is something that you'll develop as we progress throughout the quarter. You need to use objective and scientific language. If you are writing notes, you need to write legibly and use black permanent ink. And again, there's that scientific medical terminology and avoiding non-skilled language. So with the thorough, relevant, accurate, and logical, you want to do this because you want the next PT or PTA to come along and pick up where you left off. And you also want the reviewer to have a good portrayal of the patient. Like I said, with the clear and concise, you're going to take practice to become concise. With the objective language, you want to use facts and observations. You don't want to use subjective remarks that cannot be substantiated. So an example of this, let's say you suspect a patient is drunk. You wouldn't say the patient was drunk while they were at treatment today. You would make an objective statement that you smelled alcohol on the patient's breath and noted that his or her balance was impaired and they had difficulty following instructions or staying on task. And then that example of the scientific medical terminology, instead of saying the patient walked 30 feet, you would say the patient ambulated 50 feet with a forward-wheeled walker, non-weight bearing to the right lower extremity with minimum assistance for balance and cues to maintain their weight bearing status and the walker gait sequence. Okay, more guidelines for documentation. When you do intervention, and we'll get into this a little bit more, you want to include the equipment used, the number of sets and reps, and the treatment parameters. And then you guys have heard this a lot. You want to communicate skilled care. So how are your special skills and training providing assistance to the patient above and beyond what could be provided by an untrained individual? You want a description of how your skills assisted the patient, and you want your documentation to support the need for skilled services. On this last bullet point, we want to use abbreviations appropriately. Like we saw in class last Friday, abbreviations can become confusing, especially if they mean more than one thing. And the way that I need to teach you guys how to document is to write without using abbreviations. Instead you'll be writing the word out, but you still need to be familiar with abbreviations because you'll be reading notes with abbreviations and you need to know what those mean. And then I want to make one more point on that top bullet point with documenting interventions. You guys have already been doing this in last quarter, especially with therapeutic modalities and therapeutic skills and exercise. You guys were learning how to document the modality, with the parameters, and also with exercise, the equipment you use, the parameters, that type of thing. So that you guys know, you have already been doing some of this. Other guidelines are to use headings, use tables when there's a lot of information. When you do late entries, you'll need an addendum. You need to date and authenticate all patient records. Every note that we'll be doing for our lab practicals and for assignments are going to be written. But if you are on electronic medical records, there is an electronic signature within those programs, so you can't really miss doing that. We need to document missed appointments and any conversations related to patient care and any unusual or unexpected situations or results. So that might be when something happened that you have to fill out an incident report, but you'll still do a SOAP note in addition to the incident report describing exactly what happened. Okay, so now we're going to get into the subjective part of the SOAP note. So the thing to remember with subjective, it is information that is obtained from the patient, the caregivers, family members, or a significant other. The information in the subjective helps reflect the patient's response to treatment and the effectiveness of the treatment. It'll also help provide evidence if treatment is affected or if they're progressing towards their goals. So this can include the patient's status, informed consent. That is something that you guys have already been working on getting when you've been in your lab practicals. The patient's reaction to the intervention. So they may mention that an exercise that you gave them last treatment made them sore, made their pain worse, or maybe even made it feel better. You will also receive information on new problems or new complaints, and you document that in the subjective portion, and that's your change in status. And again, this is a question that you have been asking patients when you have been performing in lab practicals the last couple of quarters. And then also there might be some information that was not previously documented. I've mentioned to you guys in the initial evaluation, the patient might leave out some information for the physical therapist. And if you're seeing them on the second, third, and fourth visits following that, maybe they tell you something that they didn't necessarily tell the therapist that you know needs to be included in their note. So that initial statement by the patient about that new information would be in the subjective portion, but this is jumping a little bit ahead. You would write about telling the physical therapist about it in either the assessment or the plan portion of your note. You would want to document that you are communicating with the PT on that type of information. So the patient's status, you can get information on their pain rating and description. We've been using WILDA. So again, you guys have already been exposed to a little bit of documentation before this class. The patient's perception of their symptoms, their functional abilities, any statements that will demonstrate the patient's cognitive or emotional status. So sometimes we get patients who might be very emotional. Maybe a family member just passed away and they don't want to participate in therapy. That's a pretty significant reason. Or maybe they're not feeling well and they still participate in therapy, but they don't do so good. Or maybe we have somebody who has a little dementia and they're a little combative, or just not wanting to participate in therapy, and they say some vulgar language to you. That's where you would put their statement in quotation marks, and that way the next PT or PTA to see that patient knows what is going on with that patient. And then the last bullet point, any comments related to the accomplishment of goals or outcomes. So we definitely want to capture those so that we can use that ICF language and show that we are getting our patients better. So informed consent, you guys already know about this. You'll inform the patient of the care that will be provided, and then go ahead and do your treatment. You will probably for sure do that the first time that you're seeing a patient. If you are seeing them in subsequent visits and you're not changing anything, you probably, depending on facility, don't need to get informed consent, but if your facility wants you to get that every time you come in, you will need to do that. And then you will especially need to do it when you are starting a new type of treatment or modality. In the hospital setting, I would always, or it is good practice to go check with nursing before you see a patient. We're going to learn a little bit more about this in next quarter in advanced procedures. So that would be part of my subjective writing when seeing an inpatient is I checked with nursing. It's okay to see this patient because things can change kind of rapidly in acute care where they don't in some other types of settings. And then also, I would just do a quick statement, patient agreed to physical therapy today. So that's informed consent. The patient's reaction to interventions. So you want to know the behavior of the patient's pain since the previous intervention, if that is one of the main things you're working on. And then any comments to let you know if it's effective or not effective. Again, I gave that example earlier. If you gave them a new exercise and it made them sore, maybe it made them feel better, or you tried a new modality and they had some pain relief. Okay. Any new complaints, new pain complaints, new problems with functional activities, or a change in status. I think I went over that earlier pretty well. And then new information. Like I said, on the initial eval, the patient might leave out some information that the PT needs to know, and it could include their medical history or their environment, and their environment can include their lifestyle, their home situation, work or school situation. So those are all things that you guys might pick up after the initial eval that the PT doesn't know that they will need to know. So here are some tips for the subjective portion of the note. You want to use verbs to indicate the information was provided by the patient or the caregiver or nursing. You'll say states, reports, complains of, expresses, describes, and denies. You want to organize the subjective information by grouping similar. We usually don't split subjective into subsections, but if you had a lot of information, you possibly could do that. And then the patient quotations, I talked about this a little bit more. You would use quotations if there's some confusion or loss of memory, if they are refusing physical therapy and they might use some vulgar language in their refusal for physical therapy, their cognition or attitude, and abusive language, and that doesn't always have to be vulgar language too. So those are things you'd want to put in quotations so you know exactly what the patient said. More subjective tips, you want to include relevant information. You guys did a good job in the activity last Friday of weeding out what was relevant to include in the note and what wasn't. If the patient cannot communicate, you may not be able to include that subjective information. For instance, if you're working with a patient who's in a coma or and obviously sleeping, they can't wake up, you would put why you cannot communicate with them, and in that case, in a hospital setting, you would probably get consent from the nurse to go ahead and see them that day, or if there was a family member in there, you could do that too. So this last tip, and there's actually going to be a question and answer forum or a discussion forum on effective listening and questioning. So that is a skill that you guys will be developing, and you actually have already been utilizing it a little bit when you've been asking people about WILDA. You're doing some directed questioning. You're asking them a question and trying to get a specific answer out of them. So here are your examples of effective listening and questioning. You have analytic listening. So you're trying to get specific type of information directed. So you're listening to a patient's answers to specific questions. And like I said in that bullet point below, besides WILDA and getting informed consent, you guys are going to learn what questions to ask to get the information that you need from the patient to get a picture of how they're functioning and how they're reacting to treatment. And then attentive listening is for general information to get a total picture of the patient's situation. So if they have any physical barriers at home, how the caregiver helps the patient, you guys are going to learn to pick up on what information is important to figure out. All right, in the subjective portion, you will document about pain. And this is confusing because it seems like pain should go in the objective portion on your note. However, on the second bullet point, You're going to see documentation of pain is unique because the patient is providing the level of pain he or she is experiencing as it relates to his or her disease or disability. So pain is subjective information coming from the patient. So you will document that in the subjective portion of a note, especially as they first come into treatment. Now, if their pain changes during treatment, that can be documented in the objective section of the note. So, for an example, subjective, the patient reports their right shoulder pain is now a 5 out of 10 following treatment last week. Then in the objective portion, treatment included interferential electrical stimulation, passive range of motion, and isometric strengthening. The patient reported their pain decreased to a 3 out of 10 following treatment, period. So that is an example of how their pain changed during treatment. If you wanted to include that information on the subjective portion with patient reported their pain at a 5 out of 10 when they first came into treatment today, and then it decreased to a 3 out of 10 following treatments, that would be okay to go on the subjective, but you need to for sure have what they're first telling you about their pain in the subjective part of the note. And then there are different ways to document pain. The pain scales you guys are familiar with, the 0 to 10. There's some outcome measures or checklists, and then body drawings. And then you guys will continue to use WILDA, and that is a form of directive questioning. Okay, now we're on to the objective portion. So in the objective, you want to answer these questions. What is going on with the physical therapy intervention, and how is the patient responding to the intervention? Another good thing to consider is you want to be able to see a mental picture of the patient, the interventions performed, their response to that intervention, and their functioning before and after the intervention. You want to provide a logical flow of information, and that's where you may use some subheadings, or even when we're getting into interventions, a treatment grid or treatment log. We'll talk about that a little bit later. There again is that message. You want to demonstrate that the interventions require the skills of a trained therapy provider, a PT or a PTA. And then you have two audiences in mind when you're writing the objective portion of the note. Then again, that's what you did with the patient and how did they do with what you did with them. So another PT or PTA, so they can come along and be able to treat the patient and have good continuity of care. And then an untrained reader in physical therapy, that's your third party payer. An MD, I think, would probably get that more than others, but that way they know what you did with them. Okay, so your objective information will include the patient's readiness to participate in physical therapy. It can be information on their cardiovascular status. Other data can include their mental status, their orientation, and alertness. We've been working on alert and oriented ×3. We're going to bump it up to looking at alert and oriented ×4, and we'll learn that a little bit more in Therex 2. The interventions provided, and we're going to go into those a little bit more. You can read through the bullet points underneath them. The patient's response to physical therapy intervention provided, so their results of tests and measures, so that can be data describing the patient's function or observations. And we'll talk a little bit more about each of those. The objective section also includes the PTA's objective observations of the patient. So you're noting their gait pattern. Let's say they had a total knee replacement on the right knee, and you're noting that they are lacking knee extension at heel strike. They're not fully extending during the stance phase, and plus they're not bending their knee with the swing, or for scientific language, flexing the knee during the swing phase of gait. So those are observations that you guys can make and that you guys can write objectively in that section. A description of the patient's function that can include how are they transferring in and out of bed, what does that look like? How much assistance do they need? If you provided any patient education, which we're probably most familiar with patient education in the form of home exercises and a home exercise program, and then including what you gave them in that note, probably on another piece of paper. But patient education can also include any precautions or contraindications. I'm thinking of total hip arthroplasty precautions. You know, did you educate the patient on that? Were they able to repeat the demonstration or repeat those precautions, contraindications to you, and more importantly, were they able to keep those in mind as they went through different movements throughout the treatment? The disease process, patients are going to want some information on that, so that can be more education that you provide them, and then any family or caregiver education. So that could include teaching them how to move the patient, also informing them on maybe the disease process, that type of thing. And then if you are teaching them somebody or some home exercises programs or a functional skill, you want to comment if they were able to repeat demonstrations. So that's their reaction, or that's their how they did. So when you showed them how to do external rotation, did they do that or shoulder external rotation? Did they do it correctly, or were they moving their whole body instead of isolating that movement at the glenohumeral joint? Those are some things that you can comment on. And then it depends on the facility. Again, you may record the number of treatment sessions the patient has been seen. Some of the electronic medical records will do this automatically for you, but if you do it on paper, you know, you have to keep track of it. And in Medicare Part B, outpatient, so that's outpatient physical therapy for a Medicare patient, the PT must see them on the 10th visit, on or before the 10th visit. So in that setting, it's definitely important to keep track of how many visits you've seen them. So again, like I said, it's going to depend on where you end up working, what they're going to do. So when you do provide an intervention for your patient, and again, you guys have learned about orthopedic exercises last quarter, and then certain modalities last quarter, you guys have already been learning how to document those interventions. So we're briefly going to go over what those can include. So the parameters, what modality, exercise or activity did you do? The dosage, so for ultrasound, we know we might have done it for 1.0 watts per centimeter squared. Number of reps for an exercise and distance for walking. What equipment, the settings on the equipment, the target tissue or the specific treatment area. The purpose of the treatment, so we're using ultrasound to warm the tissue up for stretching, or we're using ultrasound to help decrease inflammation. So you guys get an idea of that. The patient positioning, that way another PT or PTA can come along and reproduce that treatment. Duration, frequency, and rest breaks. The time per treatment intervention, and then the total treatment time. We kind of started you guys on doing the time in, time out. That is something we're definitely going to hit a lot more. So on the second part of this page, you see you can use a flow sheet for the interventions, but if you do use a flow sheet, you want to make sure that these interventions show the skill of a PTA was required, and you do that by providing a short narrative. So you can have the list of exercises on a treatment grid, but let's say that they were total knee exercises. I'm going to put in my narrative portion, I'm not going to put I'm not only going to put referred to treatment log sheet like I used to get to do. I'm going to put therapeutic exercise per treatment log sheet for strengthening the right lower extremity and range of motion to the right knee and flexion and extension to progress the patient towards their goals of walking with a normal gait pattern, being able to go up and down steps, and get on and off their toilets. So you want to show that your skill was required. They needed your help to do those strengthening and range of motion exercises. And then any information that's outside of a standard procedure or unique to that treatment, it's not saying that you can't do that and you won't get paid by the third-party payers for doing it. You just need to put a reason why you might have gone outside of the box on a certain treatment. I probably have a good example of that. I've had total knee patients, and you're not supposed to call patients like that. I should be saying a patient with a total knee replacement instead of a total knee patient, something else that we'll talk about a little bit more. Anyway, they developed back pain following their surgery. So, and it was because they were walking funny. So I got an order from the doctor, and I had to do a reevaluation, reexamination as a therapist, but I also started treating their back in addition to their knee during their time with me because they developed back pain in addition to the knee pain. And then, of course, my PTA was able to carry out the treatments that I set up. So that is an example of information that's out of the standard procedure. So we didn't just rehab their knee, we also rehab their back. Okay, in the objective section, you will include measurements and tests. And as I've been telling you guys, we're going to be doing a whole session on outcome testing and measurements, but we'll get into that a little bit more. One measurement that you guys already know how to do is goniometry and manual muscle testing. You also are able to measure how far people are walking, that type of thing. So with measurements and tests, measurements need to be reproducible to provide continuity in patient care. That's why we're such sticklers with goniometry on the patient landmarks. You want to relate these measurements to what they were in the previous session or the initial evaluation. So let's say we're working on shoulder flexion range of motion, and at the initial evaluation they had 80 degrees of flexion. On their next visit, they improved to 100 degrees of flexion. And today when you're seeing them, when you measured, they improved to 110 degrees of flexion. So you could write a little statement on how it was 110 this session, and it was, I don't remember what number I said, 100 last session. You want to perform these tests and measures consistently. And then just a little note, not all the objective information that the PT gathers in the initial eval needs to be put in on each daily or interim note. So it's going to be the areas that you are most working on that you're going to include, and most likely something that was not normal on the initial eval. All right, the patient's function. So when you're talking about their function, you want to paint a picture of how they're doing. You're going to relate that function to their goal. There are standardized functional assessments, which we'll get into in a couple weeks. And this can include the functional skill, which is ambulation, transfers, lifting, stooping, standing, or bed mobility. So those are some examples. The quality of movement. So was it a smooth, coordinated movement? How were their body mechanics? Did it take a long time? What was their weight-bearing status? Those are some examples of the quality of movement. The level of assistance needed, you guys know this. This is independent, standby assistance, contact guard assistance, min, mod, or max assistance, and of 1 or 2 people. The purpose of the assistance, was it to help them physically? Was it for balance? Was it to correct a gait pattern? That type of thing. Patient position is pretty straightforward. The distances, heights, lengths, times, weights, types of surfaces. One example of height is getting up and down from a chair. A patient might be able to get up from a chair that's maybe 25 or 24 inches high, or a mat table that's high, that is that high, but they cannot get up from a chair height of 19 inches, which is, if I'm remembering correctly, what most surface heights are. What were the environmental conditions? Were you working with them on a level surface or on carpeting, outside on the sidewalk, on ramps? Were they getting out of a low chair? Was it cold? How was the light in the place? When we're talking about our neurologically impaired patients? Was it in a busy gym with a lot of distractions, or was it in a quiet room or hallway? And then cognitive status or any complicating factors. So how is the patient's understanding? Could they follow directions? Complicating factor, at their risk at falls as you were doing their vitals, did their O2 levels drop, that type of thing. So are all pieces of information on objective. And then I needed to stick this slide in here. This is from the Center for Medicare and Medicaid Services, CMS. You'll hear it referred to a lot. So anyone who reads your note should come to the conclusion that physical therapy services the patient received required the unique skills of physical therapy. And you as a PTA or me as a PT and the PTs you work with should ask ourselves, could someone not trained in physical therapy do what I just described? Selection of terms, we already talked about the verbs that you want to use, but in the bullet point below, do not use the PTA walked, ambulated, or transferred the patient. Instead, you'll put the patient ambulated 100 feet with standby assistance. Then you as a PTA provided them with verbal cues to increase left step length, manual cues at the left hip to facilitate gluteus medius contraction to decrease the Trendelenburg and normalize gait. I think that's a very functional statement. So you're saying that the patient ambulated, so that's what the patient did, but then you as a PTA provided all those cues and things, and that was part of your skill. Things that you can think about with your verbs: the PTA teaches, educates, or trains patients, or you can describe the intervention you provided as gait or transfer training, and then you want to document if there was return demonstration with or without cues. All right, here are some tips for the objective. This has kind of been drilled into your head. Patient verbs, when you describe what they are doing in the treatment, you can say the patient demonstrated, performed, or appears or is. And then PTA verbs are assisted, facilitated, verbal cueing, and manual cueing, to give you guys a little information on how to write your notes. So in the objective section, remember not to only report what the patient did, but their response or performance to the treatment. And then don't include any information that was not relevant, and you don't want it to be unorganized. So you can utilize subheadings. And on the next two slides are examples of all the subheadings that you can use. So you guys can read through these subheadings: aerobic capacity, anthropometric measurements, arousal, attention, cognition, circulation, cranial and peripheral nerve integrity, environmental, home and work barriers, ergonomics and body mechanics, gait, locomotion, transfers, balance, skin integrity, joint integrity or mobility and motor function, muscle performance, strength, power, and endurance, neuromotor development and sensory integration, orthotics, protective or supportive devices, pain, and again, when the patient tells you about it initially at the beginning of their section or beginning of their session, it's in the subjective portion of the note: their posture, any prosthetic devices, their range of motion, reflexes, self-care and home management skills, sensation, ventilation, respiration, work, community, leisure status, or integration, including IADLs. So those are the subheadings that you can use for the objective part of your note. And in some EMR systems, they might already have these subheadings, and you just go in and fill the information in by each of them. Now, assessment. So your assessment is a summary of the subjective and objective information, and it's also a summary of the patient's response to the interventions. So this is a little bit confusing because we tell you in the objective portion of the note, you don't only want to write about what they did, but you want to write about how they responded. We'll work on making that a very concise thing, but then the assessment portion of the note, it's kind of a global or a summary of the patient as a whole. And so some things you can comment about are their change in pain level, their impairments, and more importantly, their functional status. You also want to reference how the patient is progressing towards their goals. If a goal has been achieved, how their progress is going towards the goal, no progress towards the goal, or if there's been a decline in the patient's status. I want to go back to the no progress towards the goal. If a patient is not making progress towards a goal, that's not necessarily a bad thing, especially if you have a good reason why, and you'd want to state it there why you're not seeing progress towards the goal. Any changes recommended to the plan of care, you would write in the assessment portion, and then this is coming up, but you would write in the plan part of the note your plan to talk with the PT about the changes that you're recommending. And that last bullet point, the third party payers, this is where a lot of those payers and even other health professionals will go to look at the note to get a good overall view of the patient and how they're doing. So some tips for writing the assessment: you want to provide a picture of why skilled services are needed. You want to make it obvious how the interventions have led to changes in the patient's status, and then you want to use ICF language. So when including an improvement in the impairment, relate how that is going to affect their function or their activity limitation, or even participation restriction. So this is usually easily done if your PT wrote some very good and functional goals. You just get a comment right in that assessment on how they're making progress towards that goal or that function. If your PT did not write very good functional goals, you go ahead and step up to the plate and find out what function that patient is wanting to do or activity limitation they're doing. And you can go ahead and write it in that assessment portion of the note. And that is going to be an expectation that I have of you guys during this quarter, that you are using that ICF language when you are writing the assessment. Another little thing you can look at with assessment before we move on to the next slide is assessment will tell us if skilled physical therapy services are necessary, if skilled physical therapy services are helping the patient progress, and if skilled physical therapy services are improving the patient's functional abilities. So are they necessary, are they helping the patient progress, and are they improving the patient's functional abilities? So you also want to include in there if the patient has a continued need for physical therapy services. So maybe they are making good progress towards their goals, but they have not reached their goals yet. So they need to continue to come to physical therapy. And you want to also include if there's any inconsistencies in the data you obtained during treatment that day. This needs to be backed up by information in the subjective and the objective sections, and this is where you don't want to offer an opinion. You just have to objectively state what you saw. The best example that I have of this is probably with a patient who you think is malingering. Malingering is basically, quote, faking. So let's say you suspect a patient of that, and that's a whole nother lecture at a whole nother time, so we're not going to get into that too much. But let's say you saw the patient get out of their car, which was very low to the ground. They had to pick their knee up out and over the threshold of the car. They had to bend forward to get up and get out of their car, and then they walked into the clinic with no problem. As soon as you went to get them for their treatment, they started walking more slowly and holding their back, demonstrating pain behaviors. And then let's say you wanted them to bend forward for an exercise, and they said they couldn't do it because of the amount of pain, but you just saw them do that getting it out of their car. So you are not going to say in your note, the patient is malingering, he did this, this, and this. What you will say is PTA observed the patient get out of a low vehicle where the knees were higher than the hips, and the patient had to flex at his hips and his low back to get up out of the car and ambulated into the clinic with a normal gait pattern. Then you could say once in the clinic and walking back to the treatment area with the PTA, the patient demonstrated an antalgic gait and was unable to forward flex the lumbar spine to perform blank exercise or blank activity. So again, that is how you have to state those things. And if you talk about it in the assessment, you would say patient is demonstrating some inconsistent movements when they're walking into the clinic versus when they're in the clinic. That is the statement used in the assessment, but it has been backed up in the S&O portions of the note. And you could, in the assessment portion, kind of reiterate what you saw in the clinic versus when they were walking into the car. All right, in your assessment, you do not want to write these things. So you see at the top, do not document patient tolerated treatment well, or patient progressing, or patient was cooperative and motivated. Okay, if you write those things and only those things, you will get a fail for that section of your SOAP note. So don't just write those. You want to indicate how you know these things, okay? I guarantee you're going to see these statements when you're out in the clinic, but I'm telling you they are not good statements, okay? They're not telling me any information about how the patient did in therapy and if they're making any progress towards their goals, okay? So instead of patient tolerated treatment well, you could say patient tolerated the addition of 5 pounds to long arc quads and increasing the reps with squatting during treatment today. That's where you could use the word tolerated, but I would try and stay away from it as much as you could. Or if you had patient progressing, instead you would want to say the patient is progressing towards short-term goal number 1 of increasing knee flexion to 110 degrees so they can get up and down out of chairs in varying surfaces to meet their goals. Okay, so you have to back it up with something. And then again, make sure there's not any information or conclusions in the assessment portion that you did not document in the S&O section. Okay, lastly, we have plan. So the plan part of the SOAP note answers the question, where do we go from here? Okay. So the plan describes what is going to happen in the next treatment session to progress the patient towards his or her goals. It could include when the next treatment session is scheduled. If you had to consult with the PT or any involvement with the PT, you'd write it in the plan, or if it is a supervisory visit. Any equipment that you need to order and that helps serve as a reminder to you or the next person that's going to come along and see them. The number of treatment sessions before being reevaluated by the PT or being discharged. If you need to consult with any other healthcare providers or you needed to call the physician. Anything the patient or caregiver needs to do prior to the next treatment session. And then you could do a specific reminder for what to do the next treatment session or what you might want another PT or PTA to do. And if you have any concerns or recommendation for a change in the plan of care, if that's brought up in the other part of the note, you need to state your plan to talk with the supervising PT. Okay. Tips for your plan, you can use phrases such as we'll check, we'll update, we'll consult, we'll increase, or we'll hold. The plan includes anything you're thinking about doing with the patient. Again, it's a reminder for you for the next patient section and it guides the next treatment. Okay, and then here we have again a do not say continue per plan of care. If you only write that, you will receive a fail for that section of the SOAP note. Okay, you need to write something specific. You can say continue per plan of care and will progress strengthening with the lower extremity and working on going up and down stairs with holding on to only one hand railing versus 2. Or maybe you're going from a walker to a cane. That's what you want them to work on. You need to say how you're going to progress them. All right, and then again, here's some information from CMS. We need to document that care is also reasonable and necessary. So it needs to be a considered accepted standard, specific and effective for the patient's condition. at the level of complexity and sophistication that can only be provided safely and effectively by a therapist or a physical therapist assistant under supervision. For care to be reasonable and necessary, there's an expectation that the patient's function will improve significantly in a reasonable amount of time, and that the amount, frequency, and duration are reasonable under accepted standards. And on this last page, you see here are the resources. Thank you very much.